So as we discussed before, that benign prostate hyperplasia can cause acute urinary retention. So if an elderly man with a history of nocturnal frequency presents with acute urinary retention, then the cause will most likely be BPH. And how we are going to manage acute urinary retention due to BPH? The patient will present to you with suprapubic pain, inability to void, and pain will be relieved immediately once urinary catheter is put in. So the management of acute urinary retention due to BPH is insertion of a urinary catheter. And if a urinary catheter is not being able to be inserted, then the other option that we have is to insert a suprapubic catheter. So the first line is a urinary catheter, and if unable to do so, then we'll insert a suprapubic catheter. So the management of acute urinary retention is insertion of a urinary catheter, and second option is suprapubic catheter. And in men in acute urinary retention, we will do a rectal examination to see the prostate size. And in case of benign prostate hyperplasia, the prostate gland will be enlarged, smooth, and firm. And if the prostate is irregular or nodular or rough on PR, then the cause of acute urinary retention will be prostate cancer. So in men, if prostate is enlarged and normal PSA, then we will prescribe tamsulosin and a trial without catheter. So in case of BPH, after inserting the urinary catheter, when the patient symptoms are relieved, we'll prescribe the patient with tamsulosin and refer him for a trial without catheter. Trial without catheter can be tried. What are the examples of when to use a trial without catheter? One example we have discussed that a trial without catheter is done in case of BPH. And the second example during which a trial without catheter can be tried is post-operatively. What do you do? What do we do in a trial without catheter? We remove the catheter and then we encourage the patient to drink fluids so that his bladder is filled. Once the patient bladder is full, he would be asked to void, and then a bladder scan would determine the amount of urine that is still in the bladder to check that if the patient is able to urinate on his own. So if the residual volume in the urinary bladder is 200 ml, then it is acceptable. So a residual volume of less than 200 ml is considered as a successful trial without catheter, and a residual volume or a residual urine of more than 200 ml in urinary bladder after removing the catheter is considered a failed trial without catheter. Two examples when we can use trial without catheter. One is patient is unable to void post-surgery, and the second is urinary retention due to BPH. So this was all about benign prostate hyperplasia, its management, the complication of the procedure, that was delusional hyponatremia, and management of acute urinary retention due to BPH. Is it clear, everyone? If there's any question, any people can ask. Okay, the next topic is prostate cancer. The presenting symptoms in case of prostate cancer and BPH, both of them are same. What is the difference between BPH and prostate cancer? The difference is that on digital rectal examination or on per rectal examination, the prostate will be irregular and nodular. So lower urinary tract symptoms in an old male along with an irregular and nodular prostate, your diagnosis will be prostate cancer. And lower urinary tract symptoms with smooth prostate, your diagnosis will be BPH. So prostate cancer can cause local disease, it can cause locally invasive disease, and it can cause metastatic disease. Local disease uh, will present with lower urinary tract symptoms and raised PSA and nodular or irregular prostate on GRE. And locally invasive means it will invade the local structure such as urethra and urinary bladder. So it can present the locally invasive will present with hematuria, hematospermia, and obstruction of the ureter can cause loin pain, anuria, or symptoms of AKI or CKD. So if it invades the local structures such as ureter or urethra or bladder, then it will cause hematuria, hematospermia, and obstructive uropathy. And in case of locally invasive disease, we'll do a ultrasound of kidney, ureter, and bladder. Now, prostate cancer, the most common site of metastasis of prostate cancer is that it metastasizes to the vertebral column or to the bones. So it can metastasize to bones and most commonly to the bones of vertebral column. So when it metastasizes to the bones, it will cause signs and symptoms of hypercalcemia. The signs and symptoms of hypercalcemia we have already discussed in the chapter of endocrinology, and it include increased thirst and polyuria, abdominal pain, confusion, etc. So due to metastasis to the bone tissues, it will cause hypercalcemia, also bone pain. It can also cause sciatica, or when it compresses the nerve fibers of the spinal cord, it can cause paraplegia due to spinal cord compression. And in case of metastatic disease of prostate, our investigation of choice will be MRI. So a patient with lower urinary tract symptoms and on digital rectal examination, there is a nodular or irregular prostate gland, then the most appropriate next initial investigation or the most appropriate next investigation will be serum PSA, prostate specific antigen. And there are specific levels of PSA depending upon the age of the patient. For a patient who are between 40 to 49 years, if PSA levels are 2 or more than 2, then we will consider it as raised. For patient with age between 50 to 69, PSA level of 3 or more than 3, and for patients who are above 70 years, PSA level of 5 or more than 5 are considered abnormal. Remember that before performing the PSA test, men should not have an active UTI or ejaculated in the past 48 hours or exercised vigorously in the past 48 hours, or had a prostate biopsy in the last 6 weeks. Because UTI and ejaculation and vigorous exercise and prostate biopsy, they all can raise PSA levels. And therefore, before doing PSA test, you should make sure that any of them is not present. So if the patient present with spinal metastasis and there are signs of decompression, uh, sign of decompression or signs of nerve involvement such as fecal or urinary incontinence and saddle paresthesia, then the investigation of choice will be MRI. Otherwise, if only bony metastasis, no signs of decompression or no signs of nerve involvement, then our investigation will be isotope scan. So spinal metastasis with signs of decompression or involvement of nerves, we'll do MRI. And if there is no involvement of nerve, then we'll do an isotope scan. So initial investigation in case of prostate cancer is prostate specific antigen, and the definitive investigation is prostate biopsy to confirm the diagnosis of prostate cancer. While investigation in case of spinal metastasis with symptoms of nerve involvement is MRI, and spinal metastasis without symptoms of nerve involvement or compression, the investigation will be isotope scan. Prostate cancer can metastasize to bones and it can result in pathological fracture and signs of hypercalcemia, that is increased thirst or increased urination. Also, it includes abdominal pain and confusion, etc. So prostate cancer can invade the local structure, which will result in obstructive uropathy, or it can metastasize to the spinal cord and result in the compression of the spinal nerves. And the compression of the spinal nerves can cause a syndrome that is known as cardiac venous syndrome. What are the signs and symptoms of cardiac venous syndrome? They include perianal or groin numbness, also known as saddle paresthesia, inability to initiate voiding, and back pain. So back pain with nerve involvement signs such as perianal groin numbness and inability to initiate voiding, then it is cardiac venous syndrome. And in this case, I will order an urgent MRI of the spine. And if there is only back pain and no signs of nerve involvement, no numbness or no inability to initiate voiding, then we will go for an isotope scan. So a short summary of prostate cancer. An old male with lower urinary tract symptoms plus DRE reveals nodular or irregular prostate gland. The initial investigation will be, we'll suspect prostate cancer, and the initial investigation will be PSA. And the definitive investigation to confirm the diagnosis of prostate cancer is biopsy. Investigation of choice in case of spinal metastasis with nerve involvement or cardiac venous syndrome is MRI. Investigation of choice in spinal metastasis without signs of compression is isotope scan. Investigation of choice for locally invasive diseases, ultrasound of kidney, ureter, and bladder. I hope these points are clear to everyone. Is there any question?